Welcome to the Irish Practice Nurses Association online education series for general practice nurses. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA, and today we're going to look at the topic of Crohn's disease. Crohn's disease, commonly referred to as CD, is a chronic idiopathic inflammatory bowel disease. It is characterized by transmural inflammation and lesions that can affect the entire gastrointestinal tract, but most commonly occur at the terminal ileum and colon. The prevalence of CD has an incidence of 3 to 20 cases per 100,000. The exact pathogenesis of CD is unknown, although a number of genetic, immune system and environmental factors have been shown to increase the risk and lead to the aberrant gut immune response characteristic of the disease. There is both direct and indirect evidence to suggest that genetics plays a role in the development of Crohn's disease. Direct evidence can be seen because 32 different specific genetic alterations have been identified, which are more common in people with Crohn's disease than in the population at large. And indirect evidence can be seen because Crohn's disease appears to run in families. The immune system also becomes disrupted in Crohn's disease and sends tumor necrosis factor antibodies to kill all bacteria, regardless of whether they are friendly or not. TNF antibodies cause most of the inflammation associated with Crohn's disease. While Crohn's disease most often starts between the ages of 15 and 35, it can affect people of any age. Crohn's disease affects men and women equally, and it appears to be more common in people in developed countries and among certain Jewish populations. Smoking is the most notable risk factor for developing Crohn's disease, aside from family history and ethnic background. Smokers are twice as likely to develop Crohn's than non-smokers, and those who smoke usually experience more severe symptoms compared to those who do not. While there is no evidence that diet causes or plays a role in Crohn's disease, certain types of food and drink have been associated with worsening symptoms, including milk, dairy products, alcohol, spicy, fatty, and high fiber foods. There is no single diet or eating plan that will work for everybody with Crohn's disease, and dietary recommendations must be tailored individually. Although flares are sometimes associated with stressful events, there is also no evidence to prove that stress causes or contributes to Crohn's disease. There are three main phenotypes associated with Crohn's disease: inflammatory, structuring, and penetrating. Presenting symptoms are variable, and some patients may have symptoms for years before the diagnosis of Crohn's disease is made. Patients with inflammatory disease often present with abdominal pain and diarrhea and may develop more systemic symptoms, including weight loss, low-grade fevers, and fatigue. Patients with structuring disease may develop bowel obstruction, while those with penetrating disease can develop fistula or abscesses. When an abscess is present, in addition to abdominal pain, patients can have systemic symptoms such as fever and chills, and may also present with signs of acute peritonitis. Crohn's disease can affect any part of the gastrointestinal tract. 50% of patients have involvement in the terminal ileum and colon, while 30% have small bowel only involvement, and 20% of cases are isolated to the colon. In addition, 25% of patients suffer from perianal complications, including fissures and fistula. Less frequently, less than 10% of patients present with isolated perianal complaints, upper gastrointestinal disease, or extraintestinal manifestations, which can affect the skin, joints, eyes, liver, blood vessels, and kidneys. Arthritis is the most common, EIM affecting up to 25% of patients with Crohn's disease. The diagnosis of Crohn's disease can be quite difficult given that presenting symptoms can be insidious and nonspecific. Symptoms that require further investigation include weight loss, bloody diarrhea, iron deficiency, and nighttime wakening. Similarly, significant family history of irritable bowel disease, unexplained elevation in the C-reactive protein level, sedimentation rates, or other acute phase reactants such as ferritin and platelets or low B12 should prompt further investigation. There is no single test that can be used to confirm or disprove a diagnosis of Crohn's disease. The diagnosis is made on the basis of symptoms, endoscopic and radiological findings, and these include colonoscopy, biopsy, SBE, CT, MRI, and wireless capsule endoscopy. Pathology can also be confirmatory. Other conditions can mimic symptoms of CD, so it is important to rule out infection and other causes even when the patient with known CD is having a flare-up. Patients with diarrhea should be assessed for infection, IBD, and in certain cases celiac disease. Other conditions that may present similar to CD include appendicitis, Beckett's disease, and ulcerative colitis. Both Crohn's disease and ulcerative colitis are inflammatory bowel diseases, but there are some key differences. It is important not to confuse inflammatory bowel disease like Crohn's disease or ulcerative colitis with irritable bowel syndrome. Irritable bowel syndrome is a disorder that affects the muscle contraction of the bowel and is not characterized by intestinal inflammation, nor is it a chronic disease. This chart helps to explain the differences between Crohn's disease and ulcerative colitis. In Crohn's disease, the inflammation may develop anywhere in the GI tract, from the mouth to the anus, whereas in ulcerative colitis, it is limited to the large intestine. In Crohn's disease, the disease may appear in patches, whereas with ulcerative colitis, it appears in a continuous pattern. In Crohn's disease, it may extend through the entire thickness of the bowel wall, whereas in ulcerative colitis, the inflammation occurs in the innermost lining of the intestine. About 67% of people in remission will have at least one relapse over the next 5 years with Crohn's disease, whereas with ulcerative colitis, about 30% of people in remission will experience a relapse in the next year. There are several medications available to treat Crohn's disease, but there is no cure. Steroids are used to induce remission, but are not an effective maintenance agent. Steroids are usually only used to treat the active disease because their long-term use is associated with a range of adverse side effects. Budesonide and prednisolone are two steroids that are often used to treat Crohn's disease. Budesonide is usually the first choice of steroid prescribed to help control the symptoms of Crohn's. Taken on a short-term basis of less than 12 weeks, budesonide may cause acne, oedema of the face, hands, arms, feet and legs, mood changes, insomnia, and indigestion. If taken for more than 12 weeks, budesonide may cause osteoporosis, increased vulnerability to infection, cataracts, muscle cramps and stiffness, and vitamin D and calcium supplements will be required to help protect against the effects of osteoporosis. Due to increased vulnerability to infections, close contacts with people who are known to have infections, particularly those with chickenpox, measles and shingles, should be avoided. Prednisolone is used in cases where budesonide proves ineffective. It has the same type of short and long-term side effect as budesonide and has also been known to cause mental health problems in an estimated 5% of people. Sulfasalazine belongs to a group of medicines called aminosalicylate, known to reduce inflammation inside the colon. Sulfasalazine can be used as an alternative to steroids to treat mild cases of Crohn's disease. Common side effects include headache, nausea, abdominal pain, and diarrhea. Immunosuppressants are used in maintenance therapy and in combination with steroids when the person has a relapse of symptoms. Two immunosuppressants widely used for treating Crohn's disease are azathioprine and mercaptopurine. Common side effects of azathioprine include increased vulnerability to infection, bleeding, and bruising. Less common side effects include headache, shortness of breath, dizziness, nausea, and vomiting. Mercaptopurine, originally developed to treat leukemia, has since proved effective in the treatment of Crohn's disease. Given in tablet form, its side effects are not as severe as those associated with other forms of chemotherapy. Common side effects include nausea and vomiting, while less common side effects include loss of appetite, fatigue, and breathlessness and weakness caused by anemia. Effective contraception, if sexually active, is important while taking mercaptopurine, as it temporarily affects both ova and sperm, and it can increase the risk of birth defects. Biological therapies are a new type of medication created using naturally occurring biological substances such as antibodies and enzymes. Two main biological therapies are Infliximab and adalimumab. Infliximab is usually only recommended in severe cases of Crohn's disease that have not responded to steroid and immunosuppressant treatments. Infliximab works by targeting the tumor necrosis factor antibodies that are responsible for much of the inflammation associated with Crohn's disease. Given by intravenous infusion, around 1 in 4 people has an allergic reaction to infliximab, experiencing symptoms such as joint and muscle pain, high temperature, rash, and problems swallowing and headaches. Symptoms range from mild to severe and usually develop in the first 2 hours after the infusion has finished. Adalimumab works in a similar way to infliximab by targeting TNF antibodies. It is given by injection, and most people will need to have an injection every 2 weeks. Like infliximab, adalimumab increases vulnerability to infection, and those taking it should avoid contact with people with chickenpox or shingles and always report any symptoms of a possible infection to their GP. Adalimumab can cause reactivation of the hepatitis B virus and may not be suitable for people who were previously infected. Common side effects include pain, swelling, redness, and itching at the site of the injection. Headache and abdominal pain, nausea, vomiting, skin rash, muscle joint and bone pain, and respiratory tract infections can also be side effects. The goal of medication management is to control the inflammation and induce a clinical remission with pharmacological therapy. However, most patients will eventually require surgery. Unfortunately, surgery is not curative, and patients still require ongoing therapy even after surgery for disease reoccurrence. Surgery is required when the symptoms of Crohn's disease cannot be controlled using medication alone. During surgery, the inflamed section of the digestive system is removed and the remaining part is reattached. An estimated 80% of people with Crohn's disease require surgery at some point in their life. Surgery does not cure Crohn's disease, but it can provide long periods of remission, often lasting several years. A stoma may be required if the disease or inflammation is so severe that an immediate anastomosis is not safe. In some instances, the stoma may be temporary and can be closed once the severe inflammation and infection is controlled. Over 40,000 people in Ireland are living with inflammatory bowel disease. most of whom are diagnosed between the ages of 15 and 30. Of these, approximately 20,000 people experience colitis and Crohn's disease. Most Irish patients are hospitalised within 2 years of diagnosis, and more than half will eventually need surgery. A report by the Irish Society for Colitis and Crohn's disease in 2015 showed that 49% of those with Crohn's lost or had to leave a job because of their condition. The report also showed that Crohn's alone costs the health service about 185 million a year, and that paediatric cases of IBD have increased threefold in Ireland since 2003. Let's now consider the role of the practice nurse. A holistic, person-centered approach is required in the management of patients with Crohn's disease who face a lifelong condition that can be emotionally and physically debilitating. The role of the practice nurse and the clinician is to provide ongoing assessment, management, support, and education for the patient. Key roles are to establish goals and expectations with the patient for successful management of their condition, to establish a therapeutic relationship with the patient, and evaluating their physical, emotional, and psychological well-being, and to assess the patient's understanding of their condition. Common concerns for patients are adherence to their therapeutic regime, pain and discomfort. Many patients experience anxiety, anger, frustration, stress and depression. Assessment, monitoring, audit and evaluation for disease activity, progression and the effects of the therapeutic regime on a patient with Crohn's disease is a continuous process. By implementing person-centered care, monitoring and evaluating symptoms, outcomes and responses to therapy, practice nurses and clinicians play a pivotal role in managing the illness and improving the patient's quality of life. This is a list of the references that were used in the production of this presentation. Thank you for watching and listening to this presentation on Crohn's disease, which is part of an online education series for general practice nurses produced by the Irish Practice Nurse Association. My name is Teresa Lowry-Lenin and I'm a member of the Carlow branch of the IPNA. Thank you.